I'm Dr. Lindsay Baden. I'm an infectious diseases physician and investigator at Brigham and Women's Hospital, Dana-Farber Cancer Institute, and Harvard Medical School. And I will be discussing how the world changed over the last 6 months. And what you can see here are just the different names that we have dealt with the emergence of SARS-CoV or COVID-19 and how we are now coming to terms with what this pathogen has done. I have no disclosures. Just to remind everyone that prior to December of 2019, a mere 6 to 7 months ago, SARS-CoV-2 was not an issue. Curiously, in December of 2019, a pneumonia emerged of unknown cause. It was initially called Wuhan pneumonia, and eventually it was reported to the WHO at the end of 2019 when a few cases had been noted, although the etiology was unclear. Later in January of 2020, about 5 months ago, this report in the New England Journal of Medicine, as well as simultaneous reports in The Lancet, identified a novel coronavirus as being etiologic for this cryptogenic pneumonia that had emerged. The virus had been identified, cultured, sequenced. It was related to the original SARS coronavirus, which caused pneumonia approximately 18 years ago. It had some relationship to the MERS coronavirus as well, and fell into the beta coronavirus family, and was associated with some mortality. The significance of this was not fully appreciated. In The Lancet at the same time, clusters of infection in family members had also been identified and was associated with dyspnea, respiratory distress, intensive care, admission, and fatality, as we all know. The coronaviruses are an envelope-positive strand RNA virus. There are 4 alpha coronaviruses which circulate globally and we've been dealing with for decades and cause the common cold. There are 3 beta coronaviruses mentioned: SARS-CoV-1, MERS, and now SARS-CoV-2, which at this point had not yet been named. In January to February, the world watched as Wuhan, areas of China, were dealing with this emerging respiratory virus. And initially, it was associated with the wet markets. That's the darker orange. And eventually, it became clear that there was transmission among individuals not in the wet markets. And what's outlined here are different time points where different interventions occurred as our colleagues in China were responding to this unknown pathogen at the time. And eventually did identify the etiologic agent around January 10th, 11th, 12th, developed PCR diagnostics, which then allowed them to screen more widely if transmission were occurring. The medical journals at this time, including The Lancet, New England Journal of Medicine, and other major journals, all agreed that this might be a public health emergency and that data and information about this should be freely shared. This image from a meeting at the World Health Organization I attended in February, and I find this image interesting, given that at this time, it identifies when the novel coronavirus was identified, when sequences were shared with the WHO and placed in data repositories, the public health response in the locale where it was first identified, and then in red are a series of countries where cases were being identified. suggesting travel of this pathogen unbeknownst to the individuals, and eventually leading to WHO declaring a public health emergency of international consequence. This here is an image that I used in a talk done here in Boston at Harvard Medical School as we were contemplating the significance of the emergence of this pathogen. And I find this image of interest because it just shows that the first culturable virus was published on the 18th of February. The spike protein was characterized in an article published in Science on the 19th of February. Initial vaccine development had occurred and preclinical and early clinical lots had been developed. The characterization of the illness was still going on. Guidance on testing from the US FDA had just emerged. And in fact, in the US on March 2nd, there were 89 cases, 38 locally acquired. There might be community spread in California, Washington state. We were still investigating that. Suspected cases in other jurisdictions of unclear significance. This was the state of affairs about 4 months ago. Boy, how things have changed. So, what have we learned? We've learned a variety of aspects of this pathogen and the associated illness. As of middle of March, we understood that there were about 1 million cases globally, with about 10% of them being severe, 5% requiring ICU level care. Now that we're up to 10 to 15 million, these proportions are similar. There's a case fatality rate in about 1%. It depends on the patient population, the age, the pre-existing conditions, but that older individuals are more susceptible. There are severe complications, particularly in the respiratory tract, but also outside of the respiratory tract, kidney injury, cardiac dysfunction. And what I like about this image is that we have to understand that most cases are asymptomatic or mildly symptomatic, and a minority of cases develop significant illness or are fatal. So if we look at these seriously ill individuals, it by its nature is an underrepresentation of everyone infected. And that's an important consideration as we try to understand the public health implications of the spread of this organism and how to respond to it. And at this time, we were also developing a better understanding of the clinical manifestations. And this report from Dr. Guan and colleagues of the first 1,000 or so hospitalized patients in China had several salient features that still resonate today. Fever was not present in the majority of individuals when they presented. Eventually, they developed fever and cough. And again, these are hospitalized patients, not all infected patients. Some had sputum production, some had diarrhea, some had nasal congestion, but these are minor features. The incubation period was around 4 or 5 days. Lymphopenia was predominant. At times, one can see liver injury, an inflammatory state with an elevated CRP, and that the radiographic presentation was ground glass opacities in about half. This table here delineates these signs and symptoms in greater detail, but conceptually, the clinical phenotype was emerging and largely has been consistent over the last several months. These images represent non-severe injury with ground glass opacities or interstitial that in non-severe cases doesn't progress. The chest x-ray looks relatively clear, while in severe cases, one sees some lung injury with the GGOs, and then it progresses to severe lung injury, respiratory insufficiency, hypoxemia, and the subsequent consequences. This image is an example which happened to be the first case locally acquired in the US, and its clinical course, which has many illustrative features, including fever for a period of time, cough, non-productive, And what happened in this individual is they had a respiratory illness, and one sees the positive nasopharyngeal swab for SARS-CoV with an increasing CT value or decreasing viral load with partial resolution, although not completely gone. And then this individual did worse around day 12 with subsequent respiratory dysfunction that subsequently recovered, suggesting there may be a biphasic process and that nasopharyngeal sampling may be a little more um, sensitive and reproducible than oropharyngeal. And then the virus might be present in other fluids such as stool. So subsequently, we have understood that this disease process has an incubation period, has a viremia or viral illness with viral replication. In some individuals, they are viremic, but most individuals that probably doesn't occur. And then subsequently, a week, 2 weeks later, develop an inflammatory state, suggesting that there may be a biphasic illness with viral replication and response to viral infection being earlier in the illness, and then a host response or an inflammatory state later in illness, and symptoms associated with these pathogeneses. This also has implications for when therapies might be more relevant, such as antivirals versus host modifiers. This here is a compilation of data reported in Nature suggesting that those who are older have a higher case fatality. And that is something that we've seen as time has borne out, that older individuals have more severe illness, unfortunately. What we saw in the initial data out of the Seattle experience was that the majority of patients who were admitted to the ICU subsequently succumbed to complications of the illness. Of course, this is a biased population, as these were more severely ill individuals, many of whom were older individuals, but it alerted us to the significant morbidity and mortality associated with this illness, particularly in those who became clinically significantly ill. Children have been subject to much discussion with this infection. The majority of children seem to have a mild illness, but they do get sick. And there is this multi-inflammatory phenotype of severe illness. So there are severe morbidities that occur in children, although they appear to not get quite as sick as adults and older individuals. The role that children may play in amplifying the virus and transmitting the virus still requires further study to properly understand. Transmission is such an important element to understand about this virus, and how do we preempt to prevent others from getting infected. What one sees from this image in the upper right corner was an early report where an individual from China came to Germany, presented at a meeting, went back to China. At the time they were in Germany, they felt fine with jet lag. And subsequently, several attendees at the business meeting became infected and had subsequent transmission, suggesting that infectiousness may occur prior to individuals becoming symptomatic. This is the pre-symptomatic or asymptomatic concept. And unfortunately, I think this is an important element of this virus, which has allowed it to spread so widely so quickly, because many of the individuals who are infected don't know that they are infected or infectious, and so can't practice proper respiratory etiquette because they're not ill. When do people stop becoming infectious is also debatable. However, it looks like infectiousness probably is predominantly in the days prior to feeling sick and in the first week of illness. And then with immune response, one controls the virus and therefore is likely less infectious, and that's what the data show. However, one may find virus in the nasopharynx for weeks. However, the significance of this is unclear. Nosocomial transmission was identified early on and is very important to pay attention to, because if we don't practice proper precautions, it can easily spread not only in the community but in the hospital, and early reports demonstrated this. But with proper personal protective equipment, with proper masks, face shields and gowns, this can be dramatically decreased. And it's just following careful infection control practices that we all do. Where does replication occur? Um, Clearly in the throat and the nares, there is significant replication. And as this image shows, that the CT value, the lower the CT value, the more virus present, shows that virus is present at larger amounts early on in illness and decreases later in illness, eventually to the lower limit of assay, and that the nares has higher titer than the throat. And that's important to know as we think about transmissibility, diagnostics, infectiousness. This image here shows a recent report showing that nasal swabs and mid-turbinate swabs compare comparably with nasopharyngeal swabs. And this becomes important as we think about continuing to increase diagnostic capability, and how does one collect samples. And active research is going on to make it easier to collect samples than nasopharyngeal swabs, and potentially even a patient collected, which can make surveillance and diagnostics a lot easier. Data needs further validation, but I think these data are suggestive that there's opportunity for us to scale up diagnostic testing in less burdensome ways. The pathogenesis of injury associated with SARS-CoV-2 has also had significant advances. And this report, which is an old-fashioned autopsy report, but what I thought was very important is it highlights endothelial damage and it highlights thrombosis, which I think are two important complications associated with SARS-CoV-2 infection, and does lead us to certain types of monitoring as well as therapies such as anticoagulation. But endothelial injury likely plays a role in the pathogenesis and the subsequent complications later in the illness. When does viral load peak is not so clear, but likely around the time of symptom onset. And I think this is just highlighting that by the time you have symptoms, there's often a high level of virus, and you probably had a high level of virus for the days beforehand. And then it diminishes, related in part to the immune response. I think this is important because the reason I wear a mask is to protect you, not just to protect me. I don't know when I am infectious. Therefore, how do I protect others? And I think that's an important concept of transmissibility, infection control, and understanding the biology and how this virus is spread. One can find this virus in saliva, endotracheal aspirates, and a variety of fluids associated with the oropharynx. The incubation period, I already noted, was about 4 to 7 days. This is a large compilation of reports showing that about 5 days seems to be a median incubation period. It's been as short as 2 days, maybe as long as 7, or we often use 2 incubation periods to make sure that an individual is not has smoldering infection. These data I found particularly complex to operationalize. What do I mean by that? In a long-term care facility in Seattle, cases were identified. Public health authorities went in, they swabbed large numbers of individuals, residents, as well as healthcare workers, and found that about half the residents were infected who did not know they were infected and never developed symptoms, which worries me about transmissibility and pre-symptomatic or asymptomatic spread. But also that we have a lot of trafficking of healthcare workers between facilities, which just speaks to how in an open society, a lot of trafficking of individuals in different arenas can lead to transmission. And that's why masking and other types of social distancing have been discussed to minimize transmission. But these data raise the specter of silent transmission, leading to broad transmission. And unfortunately, that's what we've seen occurring across the country over the last couple of months. These data raise questions about where can the virus live and for how long. This is an in vitro experiment showing that when aerosolized on different substances, the virus can persist in the environment for a day or two or three. Cardboard maybe a little bit longer than copper. Whether or not this has any relevance to transmissibility in the community is unclear, but it speaks to the need for vigilance in hand washing and um, minimizing aerosols, face masks, so that we minimize contamination in the environment. It's unclear the transmissibility of SARS once it contaminates the environment and how long it really survives in conditions of different heat, humidity, and other stress conditions, but at least helps us understand some of the properties of the organism. Whether or not severe cases have higher viral load or longer shedding is not so clear. And that is logical that it should, but I'm not sure that the data say that that's tightly correlated. And unfortunately, in those individuals who have limited symptoms can still have high virus and shed. Therefore, we need to have universal precautions. What have we learned on the treatment front? A variety of strategies have deployed and that we've become better at, including supportive care. This includes ventilators, treating concomitant infections, use of anti-inflammatory agents, be they more general versus targeted, anticoagulation I mentioned, as well as off-the-shelf agents that have in vitro activity against the virus, such as lopinavir, ritonavir, chloroquine, hydroxychloroquine, and others. As SARS-CoV-2 binds the ACE2 receptor, much discussion has emerged about the role of ARBs or ACE inhibitors. No data are directive on the good or bad of these agents or manipulating this pathway, but it is an area of active investigation. Directly working antivirals, experimental, have emerged, as well as convalescent plasma. And I won't have time to talk about vaccines, but that's an emerging countermeasure. So the data on the different therapies, be they off the shelf or experimental, the first report of an RCT of lopinavir ritonavir came out of China in March of this year, and unfortunately did not show a benefit in terms of amelioration of disease. And though this was interesting from an in vitro standpoint, there was no evidence of a clinical benefit by improvement, and there was no evidence of decrement in viral load in the oropharynx arena. Thus, it was essentially evidence that lopinavir ritonavir did not have meaningful activity. Subsequently, much discussion about hydroxychloroquine, an anti-malarial, a drug that we use in autoimmune disease such as lupus, and observational data has emerged that did not show evidence of meaningful activity with hydroxychloroquine versus those not treated, but it's observational data, so very risk of bias based on why the drugs were used. But in RCTs that are emerging, randomized clinical trials, no benefit of hydroxychloroquine is detectable, even in this setting, when given as treatment or as post-exposure prophylaxis or early after exposure. Remdesivir is an antiviral that has emerged that has activity in vitro, for SARS-CoV-2. And in this initial report, which was compassionate use of remdesivir, there seemed to be activity, but it's very difficult to interpret given the lack of a control group, and the majority of patients get better anyway. Fortunately, RCT data have emerged, although these data are still in a preliminary report published on May 22nd. The final data set is not yet available, but these data suggested that those patients treated with remdesivir were discharged from the hospital earlier than those treated with placebo, all getting best standard of care. There was not a mortality benefit, but there was a trend of a benefit. But more importantly, these patients left the hospital earlier, suggesting meaningful activity of remdesivir. We await the final report, but these data are encouraging and have led to the remdesivir EUA and clinical availability in the US. Other strategies to treat SARS-CoV-2 include convalescent plasma. If someone develops SARS-CoV, they get better from it, they have an immune response that cleared it. Can we harvest this immune response, particularly plasma, that have high titer antibodies? Can we give these antibodies or this plasma to other ill individuals? These were some of the first data suggesting there might be a salutary benefit, but again, uncontrolled. Other uncontrolled data have been published. We look forward to randomized controlled data to better define if this therapy can work. If so, is there a titer that is needed? Is there a time in illness where it's more beneficial? Many questions, but we look forward to these types of data as it logically makes sense, but we need to understand if it's practical and real. Dexamethasone is another treatment that has emerged for SARS-CoV-2. In particular, this study out of the UK looked at individuals hospitalized with infection and demonstrated that there was a decrease in mortality in those patients who received dexamethasone than those patients who didn't. The benefit seemed focused more in those individuals who had severe respiratory distress, such as on invasive mechanical ventilation or on supplemental oxygen, while there was an inverse relationship in those not on oxygen. And maybe there was harm if you're not on oxygen, and there's benefit if you are on oxygen. More study is needed in this arena, but it suggests that in those individuals who are hypoxemic, there may be a deleterious inflammatory component, which can be ameliorated with dexamethasone or an anti-inflammatory strategy. Look forward to the full data set, look forward to additional reports looking at glucocorticoids as well as other immune modulators that are more targeted. And hopefully those data will emerge soon that will help us better direct treatment and understand pathogenesis through reverse engineering. So ultimately, we've learned a lot over the last 5 months that this virus has emerged. It has rapidly spread around the globe. There is likely pre-symptomatic or asymptomatic infection and transmission. There is a subset of individuals who become severely ill. Those individuals develop often an inflammatory state that leads to lung injury, hypoxemia. There's a thrombotic diathesis. That therapies can target the virus as well as the inflammatory response, as well as the other complications, such as thrombosis. And that we better understand transmission factors, and that we can block transmission, as was shown in Wuhan when they shut down the city for a month or two and stop further transmission. We can do that in other jurisdictions. It requires massive testing, so we know who's infected, so they can be placed at home, so they're not transmitting it. We can do contact tracing. We need to implement social measures that decrease transmission. This can allow us to reopen the economy, but do this using science to decrease the risk of transmission. We have to protect our healthcare workers so that we're able to safely care for patients. And we need to continue to develop the countermeasures such as the treatments and vaccines. And we as a community need to do this together. Otherwise, this virus will continue to spread and we will continue to have to deal with the health consequences. If you'd like to read more about SARS-CoV-2, on the different slides that I presented are articles referenced that have greater detail. And this is a very rapidly changing arena. So many of my comments may be out of date weeks from now as new data emerge. Thank you for your attention.